just a routine case for everyone. So all the orthopedic surgeons would have encountered these ACL avulsion either in pediatric age group or adult age group. So this is just a different modification of procedure. So this is an 11-year-old boy had ACL avulsion. So probably everyone would be aware of classification, that's Mayer and McIvers. This is type 2 ACL avulsion. So where the posterior hinge was intact and there was a displacement anteriorly. So the literature-wise and as per the experience, there is always a debatable about the management, either conservative or operative. But here patient had extension loss, so I decided to go for an operative management. So the routine ACL avulsion techniques are traditionally used and also for the vogue as of now even. So mainly the mini open fixation with screw or an arthroscopic pull-out fixation by 1 or 2 transfascial tunnels. So they both pose the significant risk for either a growth damage or any complications related to hardware, and also the may require the second surgery for the removal of implants. So this is the diagnostic video where this was the avulsion fracture with the displacement anteriorly and the fracture crater. So in the next video, I fixed with the temporary K-wire percutaneously to get the proper exposure over the ACL fibers where I can take my sutures and plan for the reduction. So after the temporary fixation with the K-wire, I pass my suture tape with the suture device at the substance of ACL fibers. Probably it was a very small fiber, so I decided to go for only one suture tape, that is at the mid substance level. And this is followed by the fixation with the knotless anchor, where this metal tip is going to just anterior to the fracture crater and above the physis. So that the suture tape is going along with this suture anchor, and we get the complete closure of Avulsion fragment. So this is the final reduction. This is the final reduction. There you can see this is in the around 30 degree of flexion. So there is a good contact anteriorly, anteromedial, anterolateral with the good stability of ACL fibers, where we can skip to make the tunnels over the physis and without any significant hardware. Ideally, this is a post-op reduction of the post-op check X-ray where you can see the good reductions along with the good placement of the anchor. Ideally, it would have been used with the knotless anchor with either a peak tip or either a biocomposite, but unfortunately it was not available at that time, so it was only like that. That's all.